Do we want to give the history on this one? I think we do.
Yeah,
Tremors
history is tremor.
Tremor and forgetfulness.
Right. Okay, so we don't know what kind of tremor, right? We talked about that. That can make a difference.
Okay, so I'm going to throw up a sagittal just so we can get a good feel for the brain stem, the midbrain. I think I'll even throw up a something with a little thinner slice, 1.6 millimeter, a 1.8 millimeter cut. You can see down in the right-hand corner. 1.8 millimeter separation means there's no overlap. So it looks like they used motion correction on this one because of the patient's tremor. And let's keep looking. Let's look at the coronal. Now, when you really get thin slices with overlap, you can click this button and you can reformat, and we may do that a little bit later, but in the interest of time, not now. Here's our BSI or SWI or SWAN or venous bold image, which is our blood-sensitive image. Be appropriate to check that out. Why? Well, we could have small micro deposits of amyloid which show up as punctate multiple areas of hypointensity. And we don't, but that would be an important one to check. I suggest you keep scrolling. I'm going to check out the entorhinal cortex. Patient has atrophy, generalized atrophy, and it does involve the temporal horns this time. It does involve the choroidal fissure, but admittedly, the entorhinal cortex is only mildly atrophic. It's a little worse on the right than left, but it's pretty juicy on the left. And in Alzheimer's disease, I like to see a pretty strong parietal pattern of atrophy, and I don't have that. I do have a very strong Sylvian pattern of atrophy and a moderate to strong pattern of frontal atrophy. Let's check out the sagittal to see the pattern of atrophy in the temporal region. This time, we really don't have that knife blade cutoff sign that you saw before. We do have atrophy. Looks like it involves the parietal operculum and, to a lesser extent, the temporal operculum. This is the operculum. The Sylvian fissure delimits the frontal lobe, the frontal operculum and temporal operculum, not parietal, frontal. And so the Sylvian fissure delimits those two. Let's go to the other side and check out that temporal lobe. And it's pretty symmetric, really, on both sides, frontal and temporal operculum. So you might consider Pick's disease, although the patient has a tremor, which is not a big component of Pick's disease at all. We went through the major presentation of Pick's disease: dysexecutive syndrome, motor neuron disease, aphasia. This patient had none of those. Tremor seems to be a prominent component. So we'd be thinking about things like MSA, PSP, the Parkinsonian type syndromes, Parkinson's disease. And as Dr. Schupek said earlier, it's important to try and distinguish those on imaging because certain drugs, the cinnamate-based drugs, work well in classic Parkinson's. They may work to some degree in the other disorders, and they may also exacerbate some of the other disorders. So that's something the neurologist will want to know. Let's see, let's go back to our BSI for a minute, our blood-sensitive image. This is a diffusion image. While I have it up, I'll just show it because it's here. It's negative. Let's put our BSI image up again. And while we don't see any amyloid deposits or micro/punctate hypointensities, this is an awesome sequence to look at the iron in the basal ganglia, a little bit of iron in the globus pallidus. Many of the Parkinson-like syndromes, including MSA, will result in low signal deposition in the putamen, Unlike the high signal that you saw on the T2 weighted image in Huntington's chorea, this patient doesn't have that. And let's look at the brainstem iron. That looks rather poor, doesn't it? It looks ironopenic, if there is such a word. And how about the distribution? I'm going to make it a lot bigger because that's where we're going to hone in on. And I'm going to put up the axial flare to go with it, right at that spot, and then let Dr. Shupek take over. And I'm going to make that one bigger. And let's put up the axial T2 while we're at it, and make that one bigger too. I think there is a T2 right here. And I don't think the T2 is nearly as helpful as the flare, but especially the SWAN SWI BSI venous bold image. So, Dr. Shupek, what do you think?
Okay, so the way this comes to us is tremor, okay, is part of the, so we already realized, what kind of tremor, resting tremor, intention tremor, but somebody's wondering, does this person have Parkinson's? And this is actually a relatively young patient in the 50s. Mm. So we talked about some of the findings, and actually in Dr. Pomerantz's initial presentation, he talked about some of the signs. Okay, so, and that can be very important, particularly in young patients, as far as what the treatment options, for example, there are surgical treatments for Parkinson's. Okay, so that's a really important diagnosis, meaning the patient has MSA and you treat the guy surgically, not something that you want to do. So we looked at the brain iron, and I tried to show you a couple examples earlier of the zona compacta stripe, okay, the substantia nigra, the red nucleus, okay. So the findings can be fairly subtle, and usually the first thing you see, remember Dr. Pomerantz showed you the swallowtail sign? Okay, the swallowtail sign, what it is something called the nigrosome number 1. Okay, that is in this portion of it, of the substantia nigra, there's a bright area, kind of round, oval, pill-shaped thing, okay? And that is nigrosome number 1. That's the first thing to disappear. So what you have is you have medialization of the iron, okay? That is, kind of disappears, the anatomy of the substantia nigra sort of disappears from lateral to medial, and at the same time, what's happening is, see, the zona compacta stripe is separating the red nucleus from the substantia nigra. Well, this is a neurodegenerative condition, so as these cells die off, those two bleed together, and you're just going to see a big glob of hypointensity, okay? And so those are your earlier signs when somebody that's got flat out Parkinson's way down the line, that's going to be pretty obvious, but you sort of have to get a sense of what it looks like earlier on when they're trying to establish a diagnosis. So this person does have Parkinson's, okay? So and let's just review about Parkinson's again. So resting tremor, okay? Bradykinesia, that is, the movements are slow, tiny little steps, festinating gait, okay, and rigidity, just to kind of bring you back, meaning if you're talking to the clinician, you might want to ask these questions, because if he says, oh no, he's got a cerebellar tremor, we've got to start rethinking some of these other things we've been talking about, such as an MSA-C, okay? But in this case, if he's presenting with a Parkinsonian syndrome, and we may have some basis here to support that in the imaging, okay? Now, one thing I just want to comment on before I forget about it is Dr. Pomerantz just was talking about using these gradient echo images for amyloid. So what does amyloid have to do with any of this stuff we're talking about, right? It's a hemorrhage, right? Well, amyloid is very important in the differential of, because if you go and talk to a patient sitting in the ER that's in their 70s with a hemorrhage, they talk to the family, what they're going to say is, well, yeah, actually Dad's been slipping a little bit, he kind of couldn't find his keys, he got lost in the house. So that's what precedes the hemorrhage. That's the history of amyloid. That is cognitive loss and then a hemorrhage, okay? Now we're going to see in the vascular section what some of these hemorrhages look like, but what you get in amyloid is a big hemorrhage, but with little mass effect, and it's lobar, right? It's not in the basal ganglia. like a hypertensive hemorrhage, right? Something that's in the basal ganglia, hypertensive hemorrhage. But this is lobar, big, but kind of shadowy, not really dense, bright area, but with little mass effect. So you never operate on those people. I have had that horrible experience, okay? Because what happens is you try to operate on them, you can't get out of the OR. They're just bleeding and bleeding and bleeding, right? Because it's a microvasculopathy, okay? But that can be a presentation of a dementia. That is, they'll say, oh, Dad's slipping a little bit, and then have amyloid, but they just haven't had the hemorrhage yet. So Dr. Pomerantz, what he's pointing out is you could look at this image, okay, your gradient echo or your SWI image, say, wait a second, there's a bunch of these little areas of susceptibility all over the place. This guy's got amyloid, okay, and he may come in the ER next week with the hemorrhage, okay, but when he does come in, everybody's going to know what's going on a little bit. The history will be defined, and instead of getting an unnecessary and potentially harmful operation, okay, so that would be like a really good pickup on a dementia case that's sent to you to say, this guy's got amyloid, because then they know what's going to happen and how to handle things. Okay, so that's another part of this, dementia search pattern that we're kind of developing.
And they typically don't bleed in the brainstem. It's often a bleed. It's often a bleed within a bleed. So they bleed, and then they bleed into that bleed, and then it resolves, and then they get another one in another location, and they end up with all these little punctate hypointensities. By the way, don't confuse those with calcification. There are some techniques that you can use in phase, out of phase imaging to differentiate microcalcification from iron. We'll talk about that later. But the easiest way, obviously, is to just have a CT on hand, and you'll be able to tell right away. But in amyloid, you don't get bleeds in the brainstem. In hypertension, you get bleeds in the brainstem. Now, hypertension is also a cause of multiple hemorrhages, but they usually don't end up as sort of these punctate subcortical hemorrhages, and then all of a sudden you see a lobar hemorrhage in the cortex. That is very typical of amyloid, whereas hypertension, brainstem, basal ganglia, all, where you have small vessels, usually lenticular striates, thalamostriates, is where the hypertensive hemorrhages occur. Now, we do have a swallowtail sign right here.
Right.
There's the swallow's tail. There's one tail. There's the other tail. The white thing in the middle is separating the two tails. And I put an arrow on this right here where you're starting to see the red nuclear iron and the substantia nigra iron bleeding together. You're seeing how the iron is medializing from lateral to medial in what's a very typical example of Parkinson's disease.
Now, just one point Dr. Pomerantz is talking about these hemorrhages, right? If you're going to deal with neurosurgeons, you got to, what you think of real estate agents, okay? Location, 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 okay? Anything you do that has anything to do with neurosurgery, where it is more important than what it is. Meaning we will spend all this time saying, oh, I wonder what this is. Is it this kind of tumor? Is it that kind of tumor? Is it a disc? Is it a schwannoma, right? Well, if the neurosurgeon's in the right place, he can deal with any of those possibilities. But if he's in the wrong place, okay, hemorrhage is the same way, meaning Dr. Pomerantz was talking about hypertensive hemorrhage of the brainstem, dentate, okay, basal ganglia, okay, where is it? Is it near the sylvian fissure? Could it be an aneurysm rupturing into the parenchyma, okay? So location of these things, when you see these findings, if you start thinking like the surgeons do, it's going to be really important to help you come up with an etiology for these things and appropriate treatment. Okay, and we're going to get into that as we get into spine and everything. But it's a big concept. The neurosurgeon is more interested in where it is than what it is, how he's going to get there. Is he going to be in the right place? If he's in the right place, he can deal with whatever it turns out to be. Okay, so this is going to be a big concept in spine, but also in the brain. Now, they do everything stereotactically these days, but we're going to show you that when we get to some of the strokes and things about some approaches and the tumors, that you got to know the approach, how they're going to get there, so you can comment on what issues they may have in getting to these things. Okay, so these are some of the concepts we're going to try to develop.
Yeah, Parkinson's disease, by the way, now has a subset of genetic inheritance, unfortunately, classic Parkinson's disease. They break them down into Park 1, Park 2, and Park 5. I don't know how they came up with those numbers. I think Michael J. Fox has the Park II variety, which is autosomally recessively inherited, thank goodness. And those usually have their onset somewhere between the ages of 12 and 30 years of age, so at a younger age range. So when you see somebody presenting with that, it's usually the Park II variant. The Park I and the Park V variant are autosomal dominantly inherited. Fortunately, those are a real subset. And the rest of the Parkinson's cases, we really don't know how they occur. There's been some speculation that it is a prion-mediated disease, a sort of more benign form of slow-acting viral infection. But at this point, there's really, other than understanding the chemistry, nobody really understands what the tipping point is for those non-genetic varieties. In people that have adult-onset Parkinson's disease, it's about 1 to 3% are genetic. Before the age of 30, it's 50% of them are genetic. Shall we move on?
Yeah. Okay, speech and cognitive disturbance.
So I'm going to stay with the theme of trying to get up at least one coronal image to start, one axial. I usually like to have the flare up first, and a sagittal so we can get a good look at the cerebellum, the brainstem, the midbrain, the pons, and the collicular apparatus. And this one, the superior collicular apparatus, is probably a little small, although the mammillary body, not so much. And let's check out the coronal. I think we've got a coronal T2 here. Maybe have it a little too big. Let's go right to the choroidal fissure. It's a little wide. How old is the patient?
56.
56. A little wide. Temporal horn's a little big. Entorhinal cortex looks great. So not going to be Alzheimer's disease, I don't think. You have to backtrack on that a little bit. Yeah. I haven't looked at the answer to this one intentionally, but so there is a little bit of vascular disease. Not enough to cause dementia. What's the chief complaint?
Speech disturbance, and cognitive disturbance.
Yeah. So the choroidal fissure is big. Temporal horn is a little big. And after looking at it further, the entorhinal cortex is a little flat on both sides. It's a little flatter on this side than the other side. I think you can see the asymmetry. So I changed my mind. Cerebellum not involved. So, I wanted to do one where you see how, you would go at it blind. It's not as rodent straightforward as, as some make it appear to be. And there's no brain iron. This is a standard gradient echo, not an SWI, not a blood-sensitive image, but kind of a poor man's, poor woman's blood-sensitive image. So no iron deposition, no signs of amyloid. And even though the superior colliculus is a little atrophic, I'm not overly impressed with the rest of the posterior fossa volumetric loss. There really isn't much. And I'm also underwhelmed by the amount of vascular disease. So this is one where I would consider, either ALZ or maybe even a variant of PICS. It's got some frontal predilection here, especially across the orbitofrontal region, and it's a little worse on the left than right. So I'd be wondering about, one of these Broca type PICS disease. So I'd probably be choosing those two. Would be my top two choices.
Right.
What do we know?
Well, that's the reason I showed this case was where we talked about the frontopolar that has a semantic division presentation, right? That is, it has the behavioral presentation and has a semantic, okay? And we talked about Alzheimer's. Well, actually, you know, frontotemporal and temporal, okay? So these diseases are going to start somewhere, right? Meaning, and so it's kind of, you know, these divisions are a little bit artificial. But this person, within a couple of years, you know, had really progressed to a major dementia, right? So is it Alzheimer's? Is it, you know, so this shows that those divisions are sort of maybe useful, but, you know, there's overlap and it can start anywhere. And this happened to start in the temporal lobe, wherever else it ended up, okay? And it started as a speech problem. So this is probably be classified as a frontopolar dementia of the semantic type. But, you know, as Dr. Pomerantz pointed out, if you said it would be early Alzheimer's with a temporal lobe, you know, speech area presentation, you know,
It'd be hard to disprove without a biopsy.
That may be very, very likely to be the case. Now, the biopsy was just mentioned. Pick bodies, okay, that's why it's Pick's disease, because there is a pathologic. If you did a brain biopsy, you might be able to say, yeah, there's Pick bodies here, okay. But as a clinical and radiology, you know, there might be some overlap in the presentation we could make. So I think we'd have to include both of those.
Yeah, and you know, as I was looking at it on the fly, you know, while there is some entorhinal cortex atrophy, it's not overwhelming. When you see an ALZ case, I mean, this thing is reduced to the size of a pea. So, you know, was doing a little dancing and hedging there, but as soon as I saw this, I started to change my mind. You know, this triangle right here, where the olfactory area is atrophic, the orbitofrontal gyrus is atrophic, and the great horizontal fissure is so huge. That is a very typical pattern that you see in you know, in the Pick's variations, of which you heard there are now 3. They don't call it Pick's disease anymore. And it is more left-sided than right. And as you heard earlier, semantic aphasia with dementia was previously characterized as a subset of Alzheimer's. Now it's been moved because of the histology to a subset of Pick's. So that's probably more accurate. There is a subset of ALZ with neurofibrillary tangles, tau bodies, and plaques, amyloid plaques that occurs in the occipital region. Somebody asked me about it at a course in New York. It was given some guy's name who described it Benson syndrome, described by Benson, but it really is identical to ALZ. It just happens to start in the back of the brain, and they often present with visual symptoms first, which is kind of weird and throws you off. So this is some variation of one of the semantic syndromes, probably a subset of Pick's disease.
Okay.
Shall we do another?
Yeah. All right. We're going to move on to some other things that presenting as cognitive disturbance, but a little different than what we've been talking about so far. So open your minds a little bit as you consider these. This presentation is a younger patient, 40s, who has eye problems and an encephalopathy.
So as I always do, I'm going to throw up my axial flare. And I'm going to use that as sort of my encephalopathy screener. And the eye problem aspect, we don't have an orbital study, but I am going to put up the contrast enhanced study just to make sure I don't have anything enhancing in the visual pathway. You know, we can see the globe. You can see retinal detachment and hemorrhage very easily on MRI when it occurs. And you've got the optic nerves, the intracanalicular optic nerve. They meet at the chiasm. Then you've got the optic tracts. Here's the lateral geniculate nucleus. Here's the superior colliculus. Then you go into Meyer's loop, and the stria genera and the calcarine cortex is right here. You can check out your sagittal and see if anything's happening in the occipital lobe. Here's the parietal occipital fissure. Here's the calcarine cortex. And it looks peachy, actually. It looks fine. There are no infarcts back there, and there's really no atrophy back there. Now, the sagittal flare is interesting in that there are multiple lesions in the corpus callosum. And they really are staying with the callosum. I mean, look at them. They've got a right angle orientation, and they really hug the callosum in the sagittal. Their callosal predilection isn't as conspicuous in the axial projection, and this sagittal value proposition of seeing the right angle demyelination in the callosum was really first described by the esteemed and recently deceased radiologist Bill Bradley, an original pioneer in MRI. And this case, I think, displays that. So I think the first thought you should have is multiple sclerosis based on the imaging alone. And visual symptoms, that goes with multiple sclerosis quite well. Nothing is enhancing. And in terms of a neurodegenerative atrophic pattern, not so much. We see some nice brain iron in the globus pallidus. You can see exaggerated brain iron in the globus pallidus in Hallervorden-Spatz disease, also called pigmentary degeneration of the globus pallidus, now known as panthokinase deficiency. Doesn't have that. He's got decent iron there. You can see juicy putamen compared to our Huntington's chorea case. The putamen has a normal signal intensity on flare. So how about the distribution of these lesions? I'd like to see them in the occipital region. I'm not really sure I do. In fact, I don't. I also like to see my MS plaques in the temple region, and I don't. I don't see any plaques in the temple region. Let's check out the sagittal. These are 3 millimeter cuts sagittally. Not at all. So no temporal and no occipital plaques. That's a little bit strange. So he had eye symptoms and any other symptoms?
Hearing loss.
Hearing. So you do get hearing abnormalities in MS. Vertigo is more common. Vertigo about 6 to 8%, hearing about 1 to 3%. So it's a very atypical feature for MS. We've also got an atypical distribution pattern, really confined to the periventricular and callosal region. So you got to start thinking about, MS-looking diseases. And I've got about 3 or 4 in my quiver. How many do you have in your quiver? Let's talk about a few of them. Antiphospholipid antibody syndrome. They get white matter lesions. They tend not to be so tight in the callosum. It's a vasculopathy that you see in women, and they don't get hearing loss. So that's a weird symptom. And they typically don't have visual symptoms either. It's more of a vascular syndrome. But it kind of has an MS look to it. Another one that is really a great mimicker of MS visually, not perfect but close, is Lyme disease. And those don't stay so tight to the corpus callosum, but they are periventricular, and the patients have the typical rash, and they might have joint symptoms.
Now, you would expect those to enhance or get some basilar enhancement, maybe, if it was Lyme?
They will get meningitis, but honestly, in my experience, seeing the white matter lesions probably 80% of the time is all I ever see. So I don't, even though they get meningitis, I typically don't see enhancing meningitis. And one thing I do see, we've both seen it together, is enhancement of the 7th and 8th nerve complexes. It is a cause of facial palsy, Bell's palsy. It is a cause of hearing loss. It's a cause of labyrinthitis. So that aspect of this case is okay for Lyme disease. You want it to occur, when the deer tick is out and about, which is usually the spring and summer and fall. So, if you're diagnosing a new case of Lyme disease in Toronto in 30 degrees below zero, you're probably you're probably off base by a lot. So what's another syndrome that would mimic MS? Susac syndrome, which I know one of your favorite diagnoses. So what is Susac syndrome?
Well, it's a vasculitis, okay? And as Dr. Pomerantz mentioned, it's one of these things that you think of when you see the callosum primarily involved. And that actually was the cause of this person's eye problems. They had a retinal vasculitis, as it turned out, okay? So unusual syndrome, and it differs. MS we think of as being perivenular, okay, with perpendicular orientation. This is more in the body of the corpus callosum. This is actually kind of subtle, but there's other cases that you'll see pictures of where there's actually holes in there, okay? But that's what this turned out to be, and actually, I mean, I practiced in a rural area of North Carolina, and sure, they'll say, oh yeah, well my daughter got Alzheimer's at age 40, and now she, so this is the kind of thing presenting as a cognitive disturbance that you could make a real difference by picking up that there's something going on here. Now, MS in some of its more advanced forms can have a cognitive component. Have you seen that?
Of course I have. I've seen people go absolutely crazy in the hallway on a stretcher with MS, with some of the real aggressive types, which we'll talk about later on, where there's brain atrophy, where there are holes in the head, et cetera, but not in a case like this where it's so subtle.
Right.
And I think one of the tip-offs to this diagnosis is the fact that you have eye symptoms, but nothing in the visual pathway. And the reason is they get retinal branch artery occlusion from vasculitis, which this patient had. So that should kind of at least make you think of this diagnosis. You might see it twice in your lifetime, but you know what? If you can save 2 lives, in your lifetime, you've done an amazing thing as a physician. Being a doctor is a really special thing. So at least coming up with that idea, I think, is reasonable. And the other syndrome that always comes up, when you have these periventricular and callosal white matter lesions is vasculopathy from vasculitis or simply from small vessel disease. But I almost never have trouble, differentiating the strong MS-looking disorders from these vasculopathies, because the vasculopathies, they're pretty random. They have subcortical disease. They might have infarcts. They might have atrophy. Their brain iron is distorted. They have a history of hypertension. And they don't have this, for MS, they don't have this predilection for the temporal-occipital distribution. The lesions are not right angle oriented or perivenular. And these are right angle oriented, even though this isn't MS. I mean, these are very typical perpendicular looking lesions. So I think thinking of MS as your first consideration is totally reasonable in a case like this. Also beautiful shot of the massa intermedia and the hypothalamus right here while we're at it. So this is Susac syndrome. It's a triad, and so you get hearing loss, visual loss, and something that looks like MS. That should come right to the front of your mind, even though hearing loss and visual loss certainly common with MS, but hearing loss about 1 to 3%. Vertigo, 3 to 6%.
Now, Dr. Pomerantz mentioned antiphospholipid antibody syndrome, really important diagnosis. Okay, females with a history of miscarriages, meaning somebody could be 80 years old but have had miscarriages, okay? And it's really important, anticardiolipin, because you'll see these people with severe cerebrovascular disease, and you can say, yeah, it's hypertension, but they're not hypertensive, or they don't have diabetes.
And they put them on statins, which doesn't help them at all.
Right. And so really important, and we will do that, like Dr. Pomerantz was mentioning, you got to know who you're talking to, meaning if you say antiphospholipid antibody syndrome to a neurologist, they're going to know how to work that up. But for example, if there's a physician's assistant, a GP who may not be familiar or not for a while with that diagnosis, we give them the whole workup, lipo(a), factor V Leiden, anticardiolipin antibody, okay, kind of get people on track and know who you're talking to, because if you miss that diagnosis, the patient can have a and that presentation can be headaches. Those people will get headaches. Okay, how many scans you see for headaches, all right? So, sure, there's garden variety, cerebrovascular disease, related to these other things are going to be a lot more common, but that is in there in the female patient, particularly if it's severe.
And young woman, looks like MS, got headaches. That's got to be on your list, or you're going to miss it.
Right.
Let's go on to the next case. I mean, we couldn't just show you all Alzheimer's and Pick's disease, otherwise you would have gone home.
Well, some of these cases I have been sitting on for a while, and I just had to get them in there someplace.
All right.
But Susak's, that's a good one. I mean, we don't see that too often. Okay, dementia and gait disturbance.
Dementia and gait disturbance. So, not that helpful. Very weird-looking lesion right here. Must have fallen down, maybe.
Yeah, there was a fall.
So on the right side. Don't mean to steal your thunder. I know you're scrolling, but just popped out. And, I'd go back. I'd check my axials, make sure it's blood. It is. It has methemoglobin staining. So putting it together, gait disturbance, hematoma, probably fell over. Just trying to tell the story, right? And patient's got extensive sinus disease with occlusion of the osteomeatal units. While you're looking, I'll give you some editorializing. And actually, sinus disease is very common in this particular entity for reasons we'll discuss in a few moments. In fact, it's very common in patients with all mid to late stage dementias. Has to do with airflow, swallowing, eustachian tube dysfunction. This patient has it. Now, this time it would have been lovely to have a coronal flare, and trying to see if I have a 3D flare. I don't. I have a diffusion image on the far left, an axial T1 in the middle, and I'm going to, since it's a dementia case, just have a look at the posterior fossa. Yes, there is some Vermean atrophy. There is very little hemispheric atrophy, juicy pons, normal juicy medulla. The midbrain is a little atrophic. The superior colliculus, if you go off to the side, it's a little atrophic. The mammillary body is atrophic, I will admit that. That's not a specific finding. You can see mammillary body atrophy in Wernicke-Korsakoff syndrome. You've seen it in progressive supranuclear palsy, and you can see it in this disease, which is a disease of the limbic system. And let me keep looking and see if there is a thin slice to reconstruct. There isn't, but let me try reconstructing this one on the flare just to see how it looks. It's probably going to be pretty unattractive because the slice thickness is a little too thick. But I hit my upper arrow, and now I go to coronal. No, not useful. So we'll stick with the T2. Let's bring our T2 coronal down. The findings, I think, are so profound that they show up anyway. Now, there is, as there is 15% of the time, substantial vasculopathy. But do I think that the vasculopathy could account for the dementia? You know what? An honest answer would be possibly, but it wouldn't account for the severity of the atrophy. I mean, I would describe this atrophy as severe or profound. It's Sylvian. Now, remember our case where I was waffling back and forth between Pick's and Alzheimer's and semantic disease, and I was showing you that subfrontal predilection, olfactory orbitofrontal atrophy, the diagonal area of Broca, all atrophic. Not so here. Yes, the fissure's big, but the inferior frontal and olfactory apparatus, not bad. Yes, it's atrophic, but not nearly as severe as the case that I showed you before. The Sylvian atrophy is tremendous. Before we go to the coronal, let's go to the sagittal and look at the temporal lobe. Now, the temporal lobe, it's not a knife blade pattern of atrophy. It's on both sides. It's frontal operculum, it's temporal operculum, and it doesn't just stop. It kind of fades away. Let's look at the other side. Doesn't have that abrupt cutoff. This one goes all the way back, right? That doesn't happen in Pick's disease. In Pick's disease, the hippocampus is spared. The posterior half to third of the temporal region is spared of the superior temporal lobe. Not spared here. So that's a problem. Do we have parietal involvement? We have a ton of parietal involvement. Is it worse than the frontal involvement? It is. Let's go to the other side. I'll demagnify it. It's at least as bad, if not worse. I think it is worse. And now let's go to the coronal and look at the choroidal fissures. They're huge. The temporal horns are huge. Now this time, there's no doubt. The entorhinal cortex, everything mesial to the choroidal fissure, it's just flatter than the instep of a duck. It's just straight flat across. Look at this side. Straight flat across. It looks like a moose, right? Without the horn, without the antler. There's the moose's nose right there. And massive choroidal fissure atrophy. So I think this one would be a good candidate for ALZ.
Correct. So here's your collateral sulcus, right? So everything medial to this. Okay, so this is just to kind of pull it together because, so it's not a multi-system. Dr. P
Well, if you could point to the collateral sulcus one more time.
Okay.
So between the collateral sulcus and the choroidal fissure is where you want to look. So if I...
Yeah, so it's wide and the white matter is thinned.
So here's the collateral sulcus and here's the choroidal fissure. So this is the area that you want to focus on in ALZ, and especially the top part, You don't want it to be flat. You want it to be convex up.
Right.
And sometimes, if it's sunken down, this one is a little sunken down, that's really helpful. So the one I was pointing to earlier, it was a little small, but not dramatically so. This one is absolutely dramatic, spares the posterior fossa relatively, and is slightly worse parietal than frontal, and really severe in the temporal region. And that fits perfectly for ALZ.
Right. Now, what do you do if you look at this, get an elderly patient, and see something like this, but there's no history of cognitive disturbance in the history, right? What do you say then?
Well, right? I did that once. It was a neurologist's mother, and
that's how you get hit with the frying pan by, some old lady shows up in your office.
No, he came in himself, and he said, "My mother is not demented. How dare you?"
Right.
And of course, she did have cognitive decline, but he wasn't willing to accept that. But I really took a lot of heat for that one, and I learned from that moment on, words matter. Words really matter. So how you the verbiage you use counts.
Right. Meaning, there's a lot we don't understand about this. Meaning, could somebody have these anatomic changes and be fine? Sure. Meaning, you see people walking around with giant ventricles that are fine. I would follow in my practice for years, and they never had anything. High functioning, very high, so how a particular person, it's not a destiny, So we don't want to put something on somebody's chart, right? That means they're not going to be able to get insurance, that everybody's going to start treating them differently if they're doing fine, So, and these changes, at least to some degree, are going to be present in a large portion of this, elderly population. So you got to kind of look at what they're looking for. Now, they've already said, okay, this person's really going down, and they're looking for a diagnosis, treatment. You're doing them a service. On the other hand, the patient's fine, and they came in for some other thing, a pituitary that there were, issue or something like that. I would describe the findings, but I'm not going to put that. I don't use the word in the report Alzheimer's very much. I'll say something because patients are going to get their reports before their doctors will, right? Meaning, you put Alzheimer's in, patient reads, they call up the doctor. Hey, I'm fine. What kind of radiologist you sending me to? And but I will try to telegraph things to the doctor who can say, these could be relevant if the presentation is suggestive of cognitive disturbance. Meaning, he could say, oh yeah, but you don't worry about that because you're fine.
I'm probably a little more aggressive than you are in doing that. If it says, if the history says cognitive decline or dementia, then I often give a differential. And in a case like this, I would use the ALZ word because the findings are so profound. I'd say favor ALZ over A, B, C, and D.
No, I mean, if they already have that is, they're already, they're demented, they're, okay, that's fine. But if they're not been declared demented, it's hard for us who have never seen the patient to declare some, that.
Then I would
clinical
never say it, absolutely.
And, as I say, it may change things. Yes?
The question is there a role for amyloid PET scanning in ALZ? And the answer is for research. And the reason there's not a role for it clinically, in my opinion, and in most people's opinion, first of all, it's extremely expensive. But second, it's one of many tauopathies that have amyloid, not to mention amyloid, which has amyloid in it. So it's not specific for Alzheimer's disease. So I don't think it's a diagnostic tool. I think it's a research tool. And it's mostly used to look at the amyloid burden of whatever disease process that is and whether a treatment that is being used is working. They do use it a lot, in actually animals and mice to see if, experimental treatments are working. There are 3 commercially available preparations for amyloid PET, one from GE, one from Lilly, and one from Philips. I think florbetaben, I remembered their names at one point, but now I'm old, but there's 3 of them. I think it costs about $3,000 or $4,000 to actually do the study. So I don't think there's a role for it under normal clinical circumstances, and it is not specific. It is not at all specific for amyloid. One thing I try and do with these dementias, besides, the approach that I've given you, is I kind of break them down in my head. When I'm going through the search process and trying to decide posterior fossa, supratentorial, frontal predominant, parietal predominant, how it's affecting the temporal lobe, what's the status of the entorhinal cortex, is the subfrontal region involved, what's the distribution and makeup of the brain iron. Then I start looking back at the history, I start digging a little bit. If I have to pick up the phone, I will. And then I have in my head, I go by organelle. Could it be mitochondrial, could it be lysosomal, could it be, a peroxidase? Because there's just so many of them. There's about reasonably 20 to 25, defined neurodegenerative dementias. But I've given you the big 5 or 6, including NPH and vascular disease. And then I start thinking about it, and, because there's so many things to remember, I start categorizing them by, is it a tauopathy? And then I go through the tauopathies, and I go through my checklist again. So it does take me a little longer to read a case like this than say it would a tumor case or just a headache case or whatever. And then I go through the other sort of chemical abnormalities. For instance, I didn't tell you now that Pick's disease is defined by the presence of something called TDP43. So it's actually a chemical diagnosis that's made on path. It's a type of, it's a variant of DNA. The other category of disease would be the CAG repeat polyglutamine toxicity disorders. Huntington's one of 5 of those. Then you've got synucleopathies, of which Lewy body dementia would fall into that category. And then I start, ticking all the boxes and checking the diseases in each one of those categories. And the only reason I mention that, and then there are some serotonin-related disorders too, is that it helps me sort of categorize them in my head so it doesn't drive me absolutely bonkers trying to pinpoint which group I think it is. And usually by the end, I would say 80% of the time, if the patient has cognitive decline or dementia, I have winnowed it down to about 3 disorders with one that I favor, and my hit rate is probably better than 50%. Now, I have some clinical to help me out, and I usually drill for that clinical. If I don't have it, I'll pick up the phone and get that clinical. Any other comments?
No, I think so. Do you want to hit vascular?
Sure.
All right.
Yes.
The question was, what if the dementia workup is based on CT? That is, the clinicians, and this is very common, that is a GP or non-neurologists, for example, may just order a CT as a dementia workup. Well, there's a couple of things you can figure out, right? NPH, or at least a suspicion of NPH, you could, right? Ventricles would be big. You could see transependymal spread on a CT. You could see the temporal horns being very large, right, out of proportion. You could see a huge amount of atrophy. You could see if the patient's had a ton of strokes, that could have like a Binswanger's type disease. So there's probably a lot you could do. On the other hand, if you're talking about like multi-system atrophy, Parkinson's, those sorts of things, you probably have to recommend MR for that, and you might just say that. You say, okay, the patient doesn't have NPH, doesn't have a subdural, doesn't have this, has substantial vascular disease. If, multi-system atrophy, idiopathic Parkinson's are a clinical concern, high field MR, to assess brain iron, it may be considered, because that may tick off things. Well, yeah, I didn't think of Parkinson's. Maybe that is worth looking into. So I think you tell them what you can, and there probably are some things you can do, because they may really just want to make sure it doesn't have a subdural or something like that. But there's a bunch of things you can say based on CT, I think.
Another important comment. Somebody has cognitive decline. Most of those people have what's called MCI, mild cognitive impairment. And while they won't have, flattened entorhinal cortices, what I like to do in those cases is I look at the size of the choroidal fissure in the collateral sulcus. I look at the size of this, namely the entorhinal cortex, and I look at the amount of temporal parietal atrophy, and I'll grade it, 1 through 4. Granted, it's somewhat subjective. And I'll say, in the absence of, aphasia and this, and this, findings are consistent with MCI, or mild cognitive impairment syndrome. We know that after age 60, somewhere between 5 and 10% of these individuals on a 5-year track will convert over to full-blown Alzheimer's disease. So MCI is not a diagnosis to be taken lightly, but it is a diagnosis to be made by the radiologist when you see those specific findings: parietal, temporal, entorhinal cortex, choroidal fissure, big temporal horn, not a lot of vascular disease. You have to introduce that into your report and into the differential diagnosis. On the PET question that you asked earlier, if you want to read more about the role of PET and what our colleagues in Europe think of it, go to ACTA PATH in 2009. The author is Jellinger, and discusses all the different prototypes of amyloid PET and how they use it over in Europe and in Sweden, because they're usually pretty honest, because they've got nothing to gain. It's a completely public system, and you'll see how it's used for research. Shall we move on?
All right.
By the way, cerebral amyloid is found in normal individuals who have no cognitive impairment with advancing age. That's another problem with using amyloid scanning.
Right.
All right.
And also, but amyloid angiopathy, if you look at a book, or you're going to see like a section this big about amyloid angiopathy. Boy, if you're in practice, you are seeing it every week. It's much more common. So keep it out front, because you are going to definitely see it. So this is a young patient with neck swelling who is 8 weeks pregnant.
Neck swelling, that's an interesting history. So I've put up just 3 planes myself. I've got a sagittal, an axial, and a coronal. And right now, I've got all 3 T2, which I don't like to have all the same 3 pulsing sequences up, so I'm going to swap out something different. I'm going to swap out my T1, so at least I have some variety. This is basically how I would do it if I was sitting at home. And I'll give you a moment, because this is a terribly important case. And you said she's pregnant.
Correct.
So, pregnancy, neck swelling, that should do it for you right there. I mean, Yeah, you can get leg swelling from pregnancy from compression of veins, but neck swelling, I mean, what would be your clinical differential diagnosis for that? I mean, I think you have to go thrombosis first, right? Hypercoagulable state, pregnancy, and especially for women that have certain genetic mutations, factor V Leiden, if they have both genes positive for factor V Leiden, if they're homozygous, factor VIII anomaly, antithrombin 3, and then you get some other hypercoagulable states. People with Crohn's disease who get pregnant are hypercoagulable. They get thrombocytosis. They get very high platelet counts, 600,000. Polycythemia vera, paroxysmal nocturnal hemoglobinuria, homocystinuria. So you have to be really interested in medicine to be a radiologist, and that is why radiology is so cool. I think the only thing that really comes close to it is pathology, but their patients really don't talk back, so it's not as interesting. Radiology is a lot more interesting. All right, so now that you've had a chance to digest this case, because you should make this on your own, I'm going to put the T2 back up because I think it's the easiest one to make the findings. So we said left-sided swelling, so I'm going to be looking at a mass. Maybe there could be a potential incidental mass on the left side. There isn't, then now you're giving the patient two diseases. That would be kind of silly. And you can see that there isn't much hyperintensity visible on the axial T2 because for those of you that are a little bit new to MR, even though T2 is a water-weighted image, it's not that water sensitive. It's not water sensitive like the proton density, long TR, intermediate TE fat suppression sequence is, called PD FATSAT, PD spare, PD special, PD spur. They all mean the same thing. So let's put up our PD spur and our T2 on the far right. And there's a lot of swelling in that left neck. She was not kidding. I mean, look at the disparity. So, I mean, that's all you really have to. If you're a resident on call, that's all you have to find, because now you pick up the phone and you call your attending. Say, something bad is going on here. I don't know what it is, but I need you to look at this case right away. And you're good, right? Can't miss that. So don't rely on your T2. Now, here's another reason not to rely on the T2. What if this was blood? What if it was blood at a blood vessel? What is the signal of fast flow? Black, right? What's the signal of acute blood on a T2? Black. So if you rely only on the T2 to exclude a thrombosis in a pregnant woman, and remember, they get dural venous sinus thrombosis too, you're going to go down the tubes huge, and the patient is going to suffer. Now, in this case, the clot is so big that even though it's a T2 and the clot is black, it's not that black. It's sort of black to gray, right? And what are we looking at? The subclavian. So now let's work our way up from the subclavian and see what our jugular vein looks like. Not too bad. It's a little grayer than the opposite one. I'm going to blow it up a little bit. It's a little grayer than the opposite one. But the subclavian, definitely grayer than the opposite one. And that is all clot in the subclavian. And we can see that most of the jugular is patent, but the lower part of it is not. So let's pick up the T1, because we now know that the T2 is going to be unreliable. So let's see if we can get some more reliability. Now, on a T1 weighted image, I do not want to see gray signal in a vessel, a vein, or an artery. White signal, okay. In plane, flow entry, slice entry phenomenon. First described, again, by the esteemed scientist and radiologist, Bill Bradley. But it's not white, is it? There's the subclavian vein. There's the carotid artery. There's the carotid artery on the right. There's the subclavian vein on the left. Not only is it gray, it's big. I said it looked like most of the jugular was intact. It is up high. Let's see, is it up high? No, actually not. I take it back. That is all acute clot. That is all acute clot. There compared to there. It is gray. And look how distended it is down low. The whole thing is filled in. And what else are you seeing? You're seeing subclavian thrombosis and diffuse swelling from venous engorgement and congestion. Now you might say, well, why is the T2 bright? And the reason is it's bright is it's fresh. It's fresh blood. In other words, it's less than 12 to 24 hours old. It takes at least 24 hours for blood to demonstrate intracellular deoxyhemoglobin and methemoglobin shortening. So in other words, the blood starts out, when it first becomes a clot, it's going to be gray. It's going to be gray on T1. It's going to be gray on T1, and it's going to be bright on T2, and that's what we've got. And then as time goes on, it's going to become brighter and brighter and brighter on T1. We'll call this T1. And it's going to get less and less and less bright, less and less bright on T2, and then eventually it's going to invert on T2. And how long does that take to happen? Anywhere from 12 to 36 hours is the range. So we're so early that we don't see the intracellular deoxyhemoglobin shortening effect in the vessel very well. Now sometimes on the T2, you'll be somewhere between here and here, here and here. You'll be going from high to low. So at some point, you're going to get some signal that's gray on T2. So it might be gray on T1 and gray on T2. That should never happen. So distension of the vessel, swelling of the vessel, edema of the soft tissues, gray on T1, bright on T2, but without any flow effects. It's very homogeneous. Look how bright it is. And you don't see any wispy flow effects, nor do you see smearing in the phase-encoded direction because there's no motion. So the absence of pulsation artifact is helpful. It's a sign that it's thrombosed. The fact that we see this giant thumb right here, I was wrong, all the way up high, the jugular vein is totally wasted. It's socked in by a big, gray, smooth clot. Gray, bad. Smooth, bad. Absence of pulsation phenomenon, bad. Length, bad. Edema, bad. Pregnancy, not bad, but in this case, risky. She's hypercoagulable, and she has to be checked for some of these hypercoagulable states and risks. Any comment on this?
No, except when you get a neurosurgical consult to the labor and delivery suite, you are in deep trouble. And I've seen this, but I've seen it from the other end, that is same thing, but presenting as a venous infarct. So you see the brain scan first.
Sure.
So that presenting as an acute neurologic deficit.
What do you think of the lateral sinus on this one?
Yeah, it's out.
Lateral sinus is out too?
Yeah, I'm pretty sure, yeah.
Let's see.
I think so.
I think you're right. There's the sigmoid sinus right there. That's out. That's nice and gray. And then you're starting to see a little bit of methemoglobin staining around the outside without pulsation. So that's probably out more subacutely. So that might have even preceded. It might have come from the top down into the jugular.
Right. Yeah, these people with, with some sort of blood dyscrasia or just, anything can happen. You have to be imaginative to think of like what could be going on with it. Because, as I say, if you see a brain scan and it hasn't infarcted yet, it's really easy to miss, like Dr. Pomerantz was talking about earlier. I mean, I comment on the venous sinuses and the jugular bulbs on every MR of the brain, particularly in a young female, because that's who gets these clots. Okay, now, and if you miss that, they come back, you know, the next day and you say, oh, they're not waking up now.
Yeah, I should have shown this. I apologize. I mean, look at how smooth and white that is. There's absolutely no pulsation associated with it. You can kind of follow it into the brain, too. And another thing, I was trying to think of differentials that would make sense in a pregnant woman other than thrombosis. And one other one I thought of is breast cancer. You know, sometimes breast cancer will bloom, you know, and get bigger very quickly during pregnancy if it's hormone sensitive. So you could potentially get an axillary node producing thrombosis or brachial plexus involvement. So that would be something else I might check. I mean, this is how I think about a case. I think of it from the clinical side. What could be the problem? And then I look for the findings that could explain the problem. Brachial plexus looks terrific. The axillary space wasn't completely studied, but there aren't any major nodes. And if I hadn't found the cause, I certainly would have made sure that I had a great look at the brachial plexus. All right, shall we move on?
Yeah.